by the fact that there is increased CO2. So the increased CO2 here is a partial pressure of arterial carbon dioxide that is greater than 6.7 kilopascals, or obviously this will be 50 millimeters. I don't know why I always say milliliters, but it's millimeters per mercury. And people who normally get type 2 respiratory failure are people with COPD. If it's not an acute exacerbation, and people with when a severe asthma attack occurs and there's an asthma patient is deteriorating and becoming tired of breathing, they will get type 2. So severe asthmatic will get type 2 respiratory failure, and all the other conditions like pulmonary conditions such as bronchiectasis will cause type 2 respiratory failure. I've just realized that in terms of, first of all, let me just quickly finish treating type 2. In treating type 2 respiratory failure, again, it has to do with correcting the levels of carbon dioxide and being absolutely careful that if this is a COPD patient who relies on that hypercapnic drive, so that cannot be overcorrected with oxygen therapy. So that oxygen therapy will have to be titrated based on the underlying pathology. So it's O2 therapy that's titrated. I'll emphasize titration in COPD in case their respiration is absolutely driven by the state of being hypercapnic. So there is also the ABGs, like doing the arterial blood gases. I think I'll do respiratory failure properly when I do ABGs, so that I can also focus on the compensatory mechanisms. I need new pens before I actually do a massive topic like that. So again, check the pH as well based on ABGs, and check the bicarbonate, because all of that will need correction as well. I was just going to say that in terms of bronchiectasis, I actually forgot that people with bronchiectasis and indeed people with CF will increase their residual volume and their total lung capacity. So that's really important, because in bronchiectasis there is air trapping. So that's an important point really to quickly mention. And then I've quickly covered respiratory failure in terms of the types of respiratory failures, both type 1, which is the hypoxemia respiratory failure, and type 2, which is the hypercapnia, and how they are, the underlying conditions that will cause those, and how they are to be managed. So while I'm here, since I did mention that I will look into sleep apnea, I'll just quickly cover sleep apnea as well. So sleep apnea, the definition really is episodes of absent breathing during sleep that lasts for more than 10 seconds. Usually a person with sleep apnea will enter REM sleep and they'll be breathing as normal, as they fall asleep. And and then they enter an apneic episode where they stop breathing, and then the respiratory centers will then cause them to wake up and force them to breathe again. So then they'll go back to breathing again, and then this happens again, and then over and over throughout the night. So because of what is happening, in terms of their breathing cycle, they wake up frequently. They might not be fully awake, but they do wake up frequently in order to restart breathing, and that then leads to tiredness during the day as a presenting feature, and daytime somnolence and feeling sleepy. Really, they might not even realize that they're actually falling asleep. There is also snoring. So these are the symptoms and signs. There is also snoring, but in terms of snoring, obviously it has to be the sleeping partner or indeed someone in the house. When I say snoring, I don't just mean a normal quiet snore. This is a loud snoring that can be heard, perhaps in the next room as well. And there is usually just lethargy and tiredness, really, which I've already mentioned there. So it is a disease, really, that obviously there will be a lot of psychological issues as well, because we all need sleep in order to recover, rest, and let our bodies recover. So if someone is not really sleeping terribly well, then they are missing a lot of that resting in order to get fresh and be able to be productive. So there will be a lot of psychological issues, perhaps even leading to depression. Oh, how do you spell? My spelling's atrocious. Leading to depression and emotional issues. And some marriages have broken down due to things like sleep apnea. So it is a serious condition that's disabling and reduces the quality of life, not just for the sufferer, but for people around them. Because imagine, say, if your husband or your wife or your partner was snoring every night, loudly snoring, or if they were stopping to breathe, during an apneic attack, and as the sleeping partner, you actually experience that, you witness all of that. It's quite traumatic and quite distressing to watch as well. So the partner will actually witness the apneic episodes. Oh, how do you spell? Witness those apneic episodes, which is quite dramatic. And they too will be woken up by the snoring, never mind the dramatic episodes of waking up in order to catch their breath, but they will be woken up by loud snoring. So really, everyone gets affected by this one little disease. Well, it's not really little, but, in terms of when you think about the other lung pathologies. So the underlying pathology in sleep apnea, it can be obstructive sleep apnea, which really results from a collapse of the airways. And in terms of collapsing of the airways, I'm specifically referring to the pharynx. I'm also referring to the muscles such as the tongue and other muscles behind, at the back of the throat. So in terms of the pharynx, really, there's collapse, the patent airways are like this. So there is that collapse. which then blocks airway flow, and things which, this will be the pharynx, so that will then restrict airway flow until it's completely blocked. So even if the air is coming in, if we remember where the pharynx is, it's the nose and the mouth, all leading to one tube, the pharynx. So this will be the nose, this will be the mouth. So all that air that's coming in through the nose, or indeed coming in through the mouth, goes through the pharynx in order to reach the larynx, the bronchioles, trachea really first, and then the bronchi, the bronchioles, the alveolar to become oxygenated. So all that air that's coming in, if it's coming in against a collapsed airway, so it's coming against the collapsed larynx like that, so no air, nothing will go through until obviously that signal, when air is not going through, you become hypoxemia and hypercapnic, which then just goes into the central respiratory centers, center in the brain, specifically the medulla and the pons. Well, brainstem, shall we just say brainstem, really, like posterior aspect, in fact, the medulla and the pons. So, and then they will then trigger the inspiration and expiration. So one wakes up and takes a breath, then they enter that cycle, fall asleep, collapsing of the pharynx, again back to the respiratory center. So it will go like this, and then it will go actually like this, and then back, the signal is sent back, the person breathes, but then that goes on and on and on. So there is the obstructive sleep pattern, the obstructive sleep apnea, or the central sleep apnea. Again, the central sleep apnea occurs when the medullary centers are over inhibited by the pons centers. So when the pons medullary centers when the pons respiratory centers inhibit the medullary centers, they inhibit the inspiration, the sending of the message to take in air. So, and then really basically that is the central respiratory sleep apnea. There's also the mixed type where you have both occurring at the same time. And then in terms of the obstructive sleep apnea, the breathing pattern that is seen is called the Kayan stalk. And again, it presents with episodes of breathing, episodes of apnea, waking up, breathing, falling asleep, and over and over and over. So sleep apnea itself is graded in terms of its severity, like a lot of other respiratory conditions. There is a scoring system of if it's less than 15, then it's a very mild form, and patients won't be terribly affected. It's very mild, and they might not really need any treatment. So this is from 0 to 15. However, from 15 to 30, a score of 15 to 30, scoring of disability or severity. So a score of 15 to 30 is quite moderate, and patients at this stage are actually taking, you know, self-help steps to actually try and resolve the issues, the underlying issues, and, you know, trying to keep awake. Perhaps they might even be, you know, trying to take a lot of things like caffeine, and really just trying to do anything possible to make sure that they can remain awake during the day. And they will obviously be experiencing the effects of the effect of the disease, perhaps even you know, things to do with work, particularly, you know, and perhaps even simple things such as driving a car, where one falls asleep while he's driving, or one starts to feel asleep while he's driving, and they will need intervention. And then anything over 30, sorry, this is less than 15. Anything over 30 is severe, and these are people who definitely need intervention as well. So they are experiencing a lot of symptoms. This is actually disabling in the sense that perhaps they've even stopped working, disability. They've even stopped working and stopped driving because really, you know, things are not really going well. They are falling asleep anytime. There could even be social issues in terms of a marriage breakdown because of all of this, really. So in terms of the diagnosis of sleep apnea, again, it's based on the pathology. Things that can be done, really, the most important thing are things like an oximetry, just measuring the oximetry to measure the oxygen that's available in the blood, to see if this is a much more localized issue, or if this is a central issue. And then from there, like definitive diagnostic tests that can be done are sleep studies, where a patient comes into the hospital and they spend a night in the sleep clinic. And again, this will try to measure, you know, it will measure the sleep patterns, it will measure the amount of oxygen, it will also measure to see if breathing muscles are being used in order to actually identify where the underlying pathology is. I know that I only mentioned the pharynx, but then things like, I think I mentioned the tongue as well, things like a large tongue that collapses, things like large tonsils or adenoids, anything really that that will block the passage of air from the nose and mouth, and perhaps an overbite as well, or an underbite. So once it has been determined that this is a more local issue, then treatment can be undertaken. Central causes are things like perhaps a brainstem tumor that presses on the medulla, on the respiratory centers on the medulla, or an injury of some sort. Again, you know, like brainstem injuries, which disrupt the functioning of the respiratory center, or indeed neurological conditions And again, these will need, you know, to treat the underlying pathology. So here, large. And then people who have acromegaly, because they do end up with a large tongue. So in terms of treatment, say if it's something like a massive uvula or tonsils or adenoids, they can obviously be taken out surgically. Something like an overbite or an underbite will need, can have a dental fixture that just pulls the lower jaw anteriorly, so that then a lot of room is then created at the back of the mouth. Again, this will also work for someone, say, with a very large tongue, in terms of if you pull the lower jaw anteriorly just a little bit, it then allows for, when the tongue collapses, it doesn't really obstruct the airways. Another thing to mention is that people with a large neck are also predisposed because of the fat deposition. So the most common treatment for COPD is, obviously, in terms of centrally, you know, you have to refer to neurology. But in terms of you know, and easier to correct, I'm not in any way saying anything is easy to correct, but in terms of you know, if there are no neurological issues, you can then use a CPAP, which is a continuous positive airway pressure. So this is continuous positive pressure that's applied into the airways, usually with a face mask. I would say a face mask really, that goes on top of the nose and the mouth, or it can just be the nose really. So it's usually with a face mask, a specific face mask, not the normal face mask that we use. So all it does is, when the airways are collapsed like that, it applies a positive pressure, and that pressure really just opens up the airways and allows the air to flow in. Or there can be a pipe as well, BiPAP, which works similarly, except for that it takes out air as it brings in air. Another treatment is things like dilators, like muscle relaxants, because a lot of people, you know, we think of things like CPAP and think it's a solution, but a lot of people you know, will not be happy to use it, because this is an external device. You know, it does affect people's lives. It can affect things like sleep quality, not for the sufferer, but perhaps for the partner, you know, if it's someone who has a partner. And it's an external device as well. You know, it's not really a normal general thing that one sleeps with a face, you know, a massive face on their, it's not really massive, but, you know, a mask on their face. It can also, you know, affect things like intimacy in terms of married people. So some people are quite reluctant to go into CPAP, and they can be treated medically with muscle relaxants and dilators. Oopsie. particularly theophylline. And theophylline really works by inhibiting the 4DE4, which then allows for the build-up of cyclic MP, so that muscle relaxation, bronchodilation or muscle relaxant or dilation can then occur. Actually, I shouldn't really say bronchodilation, I should just say dilation can occur. And then people can breathe. So that is a way of treating medical interventions. People with sleep apnea might also actually need antidepressants as well, particularly if it is a chronic condition that has disrupted their lives in terms of both emotionally and psychologically, and they will probably need counseling as well. And oh, I've forgotten the name of the therapy. Oh, cognitive behavior therapy. Just to sort of manage all the issues that have risen from that inability to sleep properly. And they might need marriage counsel as well if it has affected everyone in the family. So complications of untreated sleep apnea include hypertension, pulmonary hypertension, diabetes, and all the complications of diabetes, obesity. I've mentioned things like depression, and really a lot of social issues. And there might be accidents, including car accidents, and say if it's someone with heavy machinery, who works with heavy machinery. So, yeah, those are the complications that will arise from a disorder such as sleep apnea. So, in discussing sleep apnea, I've discussed what sleep apnea is in terms of, the apneic episodes that last more than 10 seconds during sleep. I have also discussed the type of sleep apnea in terms of the obstructive sleep apnea that is seen when the airways are obstructed, either by anything that causes the collapse of the pharynx, or anything such as a large tongue, large collapsible tongue, large tonsils that constrict the airways, or indeed someone with a large neck, particularly in people with acromegaly, who end up with large neck, large tonsils, large uvula, large tongue. I have also discussed the central sleeping apnea, which arises from issues with the central respiratory center, such as perhaps a tumor in the brainstem, or injuries in the brainstem, or indeed just neurological disorders that block signals being sent to the respiratory system. I have also discussed that the presentation of sleep apnea is usually tiredness, snoring, specifically complaints as well from the partner, or even if it's not just complaints, could be the partner just describing the loud snoring that's disruptive to everyone, and indeed describing the wakefulness apneic episodes that happens during REM sleep. And then I've also discussed obviously the tiredness and the complications as well that could arise from that. I have also discussed how we treat sleep apnea in terms of depending on what the cause is, is it something that can be managed surgically by removing the tonsils, shortening the uvula, or indeed, trying to create much more space in the neck, in the airways, so that they are not obstructed? Or is it something that needs just medical therapy, again working with the patient, doing what the patients want and need? So in terms of medically giving muscle relaxants, giving dilators, and trying to manage the airway so that they remain patent during sleep, or indeed moving on to the CPAP or the BiPAP, and again, if it's something centrally referring to neurology, so that whatever the underlying cause can be treated. I have, of course, discussed that how it's diagnosed specifically. The specific diagnosis is attending the sleep clinic, which then identifies where the pathology is, and the sleep pattern for obstructive sleep apnea is usually the Kyan-Stock sleep pattern. I've also discussed briefly the complications of sleep apnea, such as depression, which I already did, obesity, hypertension, and indeed having car accidents or accidents when using heavy machinery. I have also discussed how it's managed. Yep, I've done that. And I think that's it about sleep apnea. I hope I have not forgotten anything. If I have, when I review this recording, I will then cover whatever it is that I have missed out. So in the next section, I will be looking at restrictive lung pathologies, which are usually called interstitial lung disorders, which obviously affect the parenchyma of the lung and lead to a restrictive pattern of breathing.